Sir, it's 7 p.m. We can go ahead, sir.
Yeah, okay, thank you. So, good evening, everybody. I hope I'm audible and the slides are visible. So, the last time we had discussed about the supraclavicular brachial plexus. This time around, we are going to discuss the infraclavicular. But before that, just recollecting the sonoanatomy of the supra uh, scapular nerve, which you can see this is the suprascapular nerve, which is just below the omohyoid muscle. And this is isolated from the superior trunk, as you can see at this point. It is isolated from the superior trunk, and you can give an isolated suprascapular nerve block. So this is the omoid muscle, and this is the inferior border of omoid, below which the suprascapular nerve is positioned. So you can get your needle lateral to the suprascapular and block this with hardly 1 ml of local anesthetic. In fact, we had studied between 1, 4, and 7 ml, and we found that even 1 ml is quite sufficient to block, but it does not fulfill the criteria of optimal block in the sense related to anatomical aspect, that local anesthetic which goes circumferential becomes an optimal anatomic block. The second is about the isolated suprascapular nerve, where you start injecting local anesthetic lateral to the suprascapular. So this is the isolated suprascapular nerve block, and you can inject around 1 to 4 ml of local anesthetic. So this is the omohyoid muscle. So that's the local anesthetic spread. It is just around 1 to 2 ml. Then this is the extrafacial superior trunk. You can see the omohyoid, and just below that, when you inject, you can see that the drug is not going inside the brachial plexus. And the third one is the subparaneural, where you're actually going inside the paraneural sheath and injecting the local here. And at this point, you can see the spread of the local anesthetic inside the brachial plexus. So that is the subparaneural or the intrafascicular superior trunk block. So you saw the difference between the subparaneural and the sub extrafacial and the intrafacial. Now, the last time I remember, Ritesh had asked whether we can chase the local anesthetic hypoechoic shadows. You can see some of the fascicles here, hypoechoic nodules, and these are the twigs of the brachial plexus. And we are really not sure whether we are going to impale these nerves, these twigs. The third is the suprascapular nerve. You can see this is the suprascapular nerve, which is now totally bathed soaked with the local anesthetic agent at this point. And this is how you can isolate the suprascapular and block this nerve. Now, when we come to the supraclavicular brachial plexus, I just want to have a look at this video. You can see the pleural reflection at this point and at this point. So even lateral to the brachial plexus and deep at the corner pocket, you can see the brachial plexus as we ventilate this thiel embalm cadaver. This was in grass. You can see the pleural reflections here as well as at this point. So you have to be very careful during corner pocket injections as well as the lateral to the brachial plexus. You can also see the pleural movements. So you have to be very careful. And this is the reason why many of us prefer the infraclavicular brachial plexus. So coming to the infraclavicular, we are going through some dissection steps as well as the cross sections, and we try to first go through the costoclavicular and then the parasagittal infraclavicular, and if time permits, the retroclavicular and the axillary. So below the clavicle, when you start dissecting, this is the that is the cephalad. So that's the cranial end. This is the entire is the cranial end, and this is the lateral, and this is the medial side, and that's the inferior. So this is the clavicle, and you can see the clavicle is bounded by the clavipectoral fascia, which would cover the subclavius muscle, which you can see this muscle is the subclavius entirely under the clavicle. And the muscle below this, which we have reflected, is the pectoralis major, two heads, and this is the another head. And this distance is actually the distance of the pectoralis minor. So it's underneath this that the brachial plexus exists the infraclavicular, and the costoclavicular they say under subclavius. I have got my reservations for this, some controversies I do mention in some of my talks. Now, once the clavicle, clavipectoral fascia is exposed, you can see the subclavius muscle, and we go a bit more deeper. We see the subclavian vein most medial, then we see the subclavian artery, we see the lateral cord, the medial cord, and the posterior cord, and we see some nerve here. That probably is the medial cutaneous nerve of arm and the forearm, which will slowly evolve. So from medial to lateral, it would be the lateral cord, the medial cord, and the posterior cord. And you can see there is some connective tissue which still exists between the posterior and the medial cord, strong connective tissue between the lateral cord and the medial cord. So the lateral cord is most superficial, the middle cord, which would be a bit posterior, and the posterior cord, which would be more lateral. And this is all between the subclavius muscle and the superior edge of the pectoralis minor, somewhere at this point. But remember, the subclavius muscle is absolutely underneath the clavicle. In all our dissections, we found this, and this is the clavipectoral fascia, which we have removed the entire thing, and we made a rent here to expose the costoclavicular area. So the young one in yellow is the one which we target for the costoclavicular area. And this is formed by the lateral cord, which is encircled in one entire sheath, and the medial and posterior cord in another sheath, and the entire thing is engulfed in one entire circumnural uh, tissue. So this is the connective tissue that I was mentioning before, and this is another connective tissue which is more significant, which will uh, differentiate from the lateral cord and the middle and the posterior cord. And it's all lateral to the subclavian artery. This is exactly what is present in the schematics, and it's all on the second rib. Now, if you look at this particular anatomic slide, I have made a triangle here. This is the needle entry point, probably the needle entry point, which starts initially from here, which has got a very narrow space to start. And can you mute yourself, please? Sangha, please mute everybody.
Yes, sir.
And the needle entry is from the lateral aspect and it goes on to the medial aspect. And you can see that there is a narrow entry path and then it becomes very wide. And this is the reason also why the needle trajectory could be difficult in some of the costoclavicular blocks. I'm currently studying on some of the trigonometry effects of the costoclavicular and the infraclavicular, the difference between the two, which I'm going to reveal later on. So this is the again the one they have presented initially. Xavier Salablanche, my friend in Barcelona, and we have done a lot of cadaveric studies, and I might go again this year. So he has presented the anatomic topography of the costoclavicular. It's same as what we have seen earlier, but this is a front view where the clavicle and the subclavius is maintained, the vein and the artery are maintained, and you can see that the lateral cord is very superficial and just lateral to the axillary artery or the subclavian artery. The posterior cord is posterior to the artery, and you don't find the medial cord here currently. So once they the medial cord, you can see when they reflect or they pull the posterior cord, they find the middle cord, which is more posterior to the lateral cord. So this particular topography is maintained. Lateral to the axillary artery is the lateral cord, posterior to the lateral cord is the medial, and lateral to and posterior to the middle cord is the posterior cord. So the connective tissue now has been cut in between these two cords to demonstrate that they are in one single circumnurium. Now, they have cut the middle third of the clavicle to expose the entire subclavius. Until now, the subclavius wasn't seen very significantly, and that's the reason why I always mention that with ultrasound, you might see the pectoralis minor and may not see the subclavius muscle because it's such a thin muscle and lies exactly inferior and posterior to the clavicle. So it may not be possible to demonstrate it with ultrasound with a probe which is placed exactly parallel to the clavicle. Unless you look underneath the clavicle, you will find the subclavius muscle. Otherwise, you may not be able to see it. So probably with this particular probe placement, you may not be possible. You might have to tilt the probe a bit or angulate the probe so that you will see the subclavius muscle. And we have done that to identify the subclavius muscle as well. Now, once the subclavius muscle is removed, the clavicle is removed, the subclavius muscle is removed. Now we can see the entire areas. You can see the lateral cord, you can see the medial cord, and you can see the posterior cord. And yeah, the connective tissues of all these cords have been removed to expose the cords, and you can see that they lie very close to each other in a cluster sort of shape. Now, this is the cross section. Since I don't have an access to the cross sections of the costoclavicular, I do have the infraclavicular. I am taking the help of this. I call it the subclavius second rib corridor because you can see this is the subclavius muscle and that's the second rib. So between the muscle and the bone lies the entire corridor of the costoclavicular, which begins with the posterior cord and the medial cord more towards the medial aspect as well as the lateral cord and very close to the subclavian artery. They are all engulfed in one single sheath, and this is called as the circumnurium. We are coming to that terminology as well, and which rests on the rib, and which will have the serratus anterior muscle, which is a thin layered muscle, which would be entirely in this particular area. So that is how the topography of the costoclavicular. We can see again the subclavius muscle is lying beneath the clavicle bone, and the needle entry has to accept that narrow part which I demonstrated earlier, and it has to take this subclavius second rib corridor, and it's a bit difficult to engage your needle tip close to the posterior cord, more difficult to the lateral cord, and the most difficult would be the medial cord if you're trying to do a two injection technique. Now, when you do when they demonstrated with these histological sections, you could see the posterior cord and the lateral cord, which are engulfed in one sheath that's called a circumneural sheath, and the lateral cord is in one circumneural sheath. Now, so here we have a definite clustered brachial cords with a consistent topography, and which you will find that it is reproducible. But I again have my reservations against this particular terminology that it's consistent and reproducible. We will be coming to that as well again. Whether a single injection will do, whether a needle trajectory, how angulated it would be, does low volume local anesthetic work in this particular area? That's the big question here, because you feel that it looks exactly like the subclavian perivascular. If this is the subclavian artery, this looks almost like the same, and whether it is efficient and it's predictable. I have my questions and I have my reservations against the costoclavicular block. Now, the terminology circumnurium. You can see that this green structure, which goes around the cords, around all the three cords and around the vessels, is the circumnurium. So, and there's another circumnurium which is going between the lateral cord and the posterior cord, but there is no circumnurium which is going along this area. And this is the axillary artery, and the vein would be still more medial, and this would be a part of the lateral cord, and usually it's the lateral pectoral nerve, and these are the parts of the medial cord, which could be probably the medial cutaneous nerve of arm or the forearm, and this would be another branch from the arising from the posterior cord. This is the connective tissue which lies beyond the circumnurium. This is the connective tissue which lies beneath the circumnerium. So naturally, this becomes the entire structure. It becomes the intraneural part. The intraneural part again divided into the extravascular. So this becomes the internal epineurium actually, and this would be the perineurium, which all goes around this, and this would be the endoneurium. So you've got definitive structures here which can be seen histologically, of course, cannot be differentiated with ultrasound, but you need to have to be carefully position your needle tips in these cases. So what is circumnerium is nothing but paraneurium. Now this is a replacement term since 2019. This was introduced by the Force. Now Force is a Society of Fascial Osteopathy, and they recognize that the circumnerium is the term which has to be used instead of paraneurium. So in case if they are using the term circumnerium anywhere in the talks, it is exactly the paraneurium, and it is the outermost connective tissue which envelops a peripheral nerve, which is external to the epineurium. So you have epineurium, and you have the circumnerium which goes around. So that's how the circumnerium is the exactly the paraneurium. Now, this is what we are looking from the front. This is the front view. Again, this is the clavicle, the subclavius muscle. That's the vein, the artery, and this is the lateral cord, the medial cord, and the posterior cord is still more uh, deep and beneath the medial cord. And you can see the emergence of the lateral pectoral nerve, which goes on to innervate the pectoralis major here at this point, which we have seen also on the histological slide. So what happens actually here is that when you have the needle entry towards the lateral cord, you are you have a very narrow lateral entry. What we have seen, a wedge-shaped space with a narrow lateral entry, and you have to dive deep below the clavicle and the subclavius roof, and you will gain access to the lateral cord. So with this, the needle visibility might be compromised in these cases when you do that. And more so ever, when you try to angulate your needle towards the posterior cord or between the medial and the posterior cord, it could be even more challenging in some of the uh, patients for costoclavicular block. So it's not that the needle challenges the needling would be more easier. In fact, it would be more challenging in costoclavicular blocks, and it depends upon the depth of the costoclavicular brachial plexus and the height between the clavicle subclavius roof and the plexus. That's going to determine the needle angulation. And more so ever, the distance between the needle entry at this point and the distance from the needle entry to the brachial plexus. So the height and this distance is going to determine the angulation, and this is going to be a challenging in some of the costoclavicular blocks. While the out of plane in this case, many of times we do the out of plane technique, it becomes more easier to insert the needle just through maybe the subclavius and the pectoralis major and the subclavius, and just point your needle in between the lateral cord and the medial cord, and you inject a local anesthetic. The big challenge again here is to identify the needle tip, as is a problem with the out of plane techniques, and you need to be very cautious to identify the needle tip. Now, this is what we are trying to do. We are trying to evaluate the costoclavicular excess through a formula which we have learned in geometry. This is something that the students may find it difficult. Even I am finding it difficult. But this is what we are trying to find out. We try to find out the tan theta against the height. That is this is the particular corridor that we are trying to find out. And in one of the case, we found that the needle must descend 1.6 millimeters for every 1 millimeter medial travel. It means that it's going to be very steep. So it all depends upon the tan theta. If it is around 0.56, for example, the trajectory is going to be very steep and the corridor is going to be very tight, and it's very difficult to access this. So this is what we are trying to imagine how it can be easy, moderate, difficult, and very difficult based on some of these values. So these values are just imagined by us. It's not that what we have confirmed, but we're trying to do that now. Now we know that this is the circumnurium. The green is the circumnurium, and this is the one which goes around these two chords, and this is the one which goes around the lateral chord, and that's the perineurium, and the one which is the endoneurium. So we are looking at the needle placements, whether this is the correct needle placement, which is just at the circumnurium, and we have not challenged it, or we have not penetrated or perforated the circumnurium. So that could be probably the best way to inject local anesthetic. And this can be at a couple of points, like towards the lateral cord and towards the bunch of the posterior and medial cord. We are not trying to penetrate beyond the circumnurium. Now, if we penetrate the circumnurium, that becomes probably it becomes intraneural, but it's not going to cause any peripheral nerve injury histologically, because the local anesthetic can spread in the internal epineurium, or it can be in the all the connective tissues, and it's not going to cause a damage to any of these cords. So this is quite acceptable. But with ultrasound, you cannot really distinguish between the circumnurium and the epineurium, as we will see in some of the videos eventually. You can as well target the lateralmost aspect of the posterior cord by going through the circumnurium. But again, as I said, the same thing applies here if you are going to do that. Now, if you go still more deeper, you're going more closer to the lateral cord, and that's going to be again very challenging, and that may be quite unacceptable when you do the needling in between the two cords, where histologically you can see that they have an internal epineurium. So your drug is going to go intraneural, but it's going to be extravascular. So that's not a problem, but really you cannot distinguish with ultrasound. But maybe with high resolution ultrasound nowadays, we can really distinguish with the current modalities. You can really distinguish between the tip placements in the innermost areas, like going beyond the circumnurium and trying to inject in between these two cords. You can really see those structures now, and probably you might inject in future very close to the cords, and it can be intraneural as well. But for now, when the students they follow, it's always has to be the paraneural sheath or the circumnurium, and it's never intraneural. So these are some of the placements of the needles. It can be just a single placement of the needle where you can inject at the lateral cord, and then you can have a double injection where you can inject at in between the lateral and the posterior cord. Now, this placement, again, you'll find that this is the axon, that is the perineurium, and this is the internal epineurium of the fascicle. Whether you should inject in this area, it's a big no. Your needle has to be positioned at this particular point. So it's always in the paraneural sheath, and it's never inside the uh, beyond the circumnurium or very close to the perineurium. This, of course, is again a histologic diagnosis, the endoneurium and the perineurium. This layer perhaps you might see with high resolution ultrasound. Now, when you needle, what are the critical structures that come in your way? Now, this particular cadaveric study, they demonstrated that there are a couple of structures that come in your way. The one is the medial antebrachial cutaneous. The second is the medial brachial cutaneous. The third is the lateral pectoral nerve, which they have mentioned in the literature. And the fourth is some of the vessels, which abnormal vessels that might come in your way. So these has to be looked into. Now, the problem is these nerves, even if you use a nerve stimulator, you may not have paresthesia unless you use very high current, which is, of course, we don't use it in patients with fractures. So it's highly unlikely that you would be confirming these nerves before you advance your needle tip very close to the brachial plexus. Now, these are some of the structures that they have encountered. Of course, the lateral cord, the medial and the posterior cord, the medial antebrachial cutaneous nerve, the lateral pectoral nerve to some extent, the medial pectoral nerve to some extent, the cephalic vein, thoracoacromial artery, the subclavian artery, and the subclavian vein. So these are some of the structures that they have come across or encountered when the needle entry was from the lateral to the medial. Now, let us look into this particular image. Now, this is the costoclavicular, this is the artery, and you can see that this is the circumnurium. The orange one is the circumnurium, which is now enclosing the entire artery, the vein, and the entire brachial plexus. This is, of course, the lateral cord, that's the medial cord, that's the posterior cord, and there are some structures, neural structures, which I'm unsure about what exactly they are. This is perhaps the lateral pectoral nerve, which resides in the pectoralis major. Now, again, I question myself, what are these? Are these really the neural elements? Because we see many times that apart from lateral, medial, and posterior cord, try to look at the structures which are more lateral to the posterior cord. Perhaps they could be some of the neural elements. Now, when we have a needle placement, you can see the needle placement is through the pectoralis major, the subclavius muscle, and the needle tip has just penetrated the circumnurium, probably the circumnurium, because this is the hyperechoic shadow that I'm targeting. That's a non-neural structure. So this is the way that the needle has advanced through the circumnurium or the paraneural sheath. So one of the ways to target is to target the entire paraneural sheath. So follow this paraneural sheath or the circumneural sheath where it ends, and where this ends, that particular area where these two ends, it gets more thickened. So it is at this point, the thickening of the two circumneural areas, it is this point where you uh, advance your needle without uh, coming close to any of these neural structures, and then you can start injecting your local anesthetic. Now, once you start injecting local anesthetic, you will find that the circumneurum is still preserved and there is sheath which is elevated here. So this white hollow arrows is the sheath which has been elevated, while this is still retained. You can see that this is still retained its structure. Now, when you inject still more, so this is 5 ml of local anesthetic, then you inject another 5 ml. Now you will see that the circumnurium is still preserved. The needle tip is, of course, here below the original circumnurium, and you can see some of the facial sleeves, like these green ones. These facial sleeves are elevated. So these facial sleeves are now elevated, and the local anesthetic percolates beyond this. So we have seen this as well as in the supraclavicular, in popliteal, and now we are seeing, of course, in the costoclavicular area as well, that there are numerous facial sleeves which are elevated as you start injecting local in the circumneural area. Now, if you see that the local anesthetic has uh, nicely delineated all the neural structures. These are all the neural structures that are delineated here. And you can see that there are multiple neural structures. It's not only the lateral, posterior, and medial cord, but you can see a lot of these neural structures. And we see a lot this every time when we start injecting local. So you need to carefully pick up these neural structures. And now you can see that there are a couple of sleeves which have been elevated. This could be the one, this could be the second one, this is the third one, and this is the fourth one which have been elevated. And the local anesthetic now is exactly very close to the brachial plexus, and this all along the concentration gradient. They're going to go inside the nerves and block the action potentials. So these white arrows are all the neural elements. This is the external most. This is the internal one, and this is the needle tip. Now, Once you start injecting local, you will see that some of these sheaths are elevated. If you can see this, these are the neural sheaths. These are elevated, and the local anesthetic is percolating here more inside. You can see that there's one sleeve here, there's a second one here, and there's the third one here. So multiple sleeves, and the local anesthetic spreads. The second thing what you can do is you can get your needle just beneath the brachial plexus here at this point and start injecting local and try to elevate this from the muscle here, which is the serratus anterior. You can elevate this brachial plexus if you want to, but you really need not do this because you're giving around 20 to 25 ml of local anesthetic, which is going to give you a good brachial plexus block. So this is very important as the local anesthetic, it penetrates more inside when you start injecting, and you'll always find I have not moved the needle tip. The needle tip is remains the same here, and in the previous slide it remains the same. You start injecting, it raises the sleeves of the uh, facial layers. Now you can see the entire sheath which is elevated. This is one compartment, entire one compartment. This is second compartment of injection. So probably in the first 10 minutes, this local anesthetic gets absorbed and the brachial plexus block is ensured. And in another 10 minutes, this local anesthetic also along the concentration gradient is going to get absorbed into this unless this has got any volume which is sufficient for to absorb. So that is the reason why the if you scan at the end of maybe 1 hour, you can still find some local anesthetic remaining at the end of this, and this might lead to a more prolonged block. So all along the concentration gradient, it's going to go inside the nerves. I'm not sure what this particular structure is, which we found consistently remaining at this particular point. We did not use as a neurostimulation, so I'm not sure whether it's a neural structure or a non-neural structure. Now, this is a video clip of uh, the costoclavicular block, and this you will find that probably I've used an out of plane technique here, and you can see the bed which is getting elevated here. So the needle, if you're not seen, that means it's not in view. So it has not trespassed the brachial plexus. It's probably gone more posterior to the uh, brachial plexus, but it has elevated the entire brachial plexus from its bed, which could be the serratus anterior. This is the secondary. This is the artery. That's the pectoralis major. That's supposed to be the subclavius muscle. So again, just to demonstrate how it's lifted from its bed. So that can be utilized as one of the techniques. We use a lot of out-of-plane techniques for the costoclavicular blocks, and we hardly use the lateral approach, but you can use either of these. That's one more elevation of the out-of-plane. And here you can see that this is entirely engulfed. There's one more sheath here. There's one more sheath here. So one, two, and the third sheath. So the couple of sheaths here which engulf the brachial plexus cords. Now, in one of the articles that we published in a retrospective study, we found that, as I said earlier, it cannot be just the lateral cord, the medial cord, and the posterior cord, but you get a couple of divisions. Like we saw that we had almost 4 to sometimes 8 divisions, neural elements rather, in the costoclavicular space. And this could be a transition from the divisions to the cords. So just as the divisions, they may not just end at the level of the clavicle, they may continue beyond the retroclavicular, they may continue into the costoclavicular space, and they may still remain as divisions. And perhaps if you have been looking and your brain has been impregnated with the thought that the brachial plexus at the level of the costoclavicular is just the lateral, medial, and posterior cord, and you might fail noticing all these neural structures. And if you fail to look at the structures maybe at this point beyond 3B and you don't inject here, you might get a failed block. So you need to have look at the entire brachial plexus in the costoclavicular space. Here as well, you find that this is the lateral cord, this is the middle cord, and this is the posterior cord. So beyond 6 now, if you're not looking at these neural elements, and you don't inject local anesthetic here, perhaps you might get a failed block in the form of a cutaneous failure or maybe a myotome failure. So these things have to be looked for when you do a costoclavicular brachial plexus. Now, when I started some contrast studies, I will show you some contrast studies, very interesting. This is the clavicle, and this is the dye which is spreading below the subclavius muscle. And this is the serratus anterior, that is the subscapularis muscle, and the dye is exactly occupying the costoclavicular area. Now, when you have another view, you can see that the dye is going beyond the clavicle. This is the second rib. So we have injected somewhere at this point, and you can see that the dye is ascending between the scalene muscles here. So that's the anterior scalene, that's the medial part. This is the middle scalene, that's the levator scapulae. This is the spine of the scapula, the subscapularis, supraspinatus, infraspinatus, trapezius, the second rib and the third rib. The serratus anterior will be going above this, and this is the intercostal muscles. Now, in the axial plane, again, this is the clavicle, this is the subscapularis, the dye is occupying exactly the costoclavicular space. This is the space which is again of very much importance, which I will be coming to it later on in the infraclavicular block. Now, when we did the 3D, that is volume rendering technique, we found that when we were injecting at the level of the divisions and chords, that is, this is the costoclavicular area, the drug is going caudal in the infraclavicular, that is fine. The drug is going retroclavicular, that is fine, that is perfect. But moreover, it's going in the supraclavicular area, it's going at the level of the divisions, the trunks, and then it's going at the level of the cervical root. So this could be uh, it could be beneficial if the costoclavicular block, when you inject around 30 to 40 ml of local anesthetic, if it occupies this space, that's going to be a block of choice for many, for the even for the shoulder surgeries. But this is not a predictable, or it is not reproducible. So probably if you are going to inject very high volumes of local anesthetic, of course, which you are not going to inject in high concentrations, it becomes an analgesic block. So when I injected around 20 ml of contrast, I found that it reached almost the level of the cervical roots. So this we had published in one of the in the literature that's looking from below. This is rib 4, 3, 2, 1, and you're looking from below towards the clavicle, and beyond that, this is the supraclavicular area, and this is the infraclavicular area. So we published this where we used the stimulating catheters in a costoclavicular block in a case series where we used the stimulating catheter. We introduced it retrograde. I wanted to find out whether we can stimulate the brachial plexus in the supraclavicular area from the infraclavicular. So when we rotated the needle around 90 degrees and we inserted a needle, we found that the contractions of the biceps and the deltoid, which is very characteristic feature of the superior trunk or even the interscalene area. And when we positioned the catheter there and we injected local anesthetic, we found that the patient had good shoulder analgesia. So we used it for shoulder surgeries. For the post-operative pain relief, of course, all patients were under general anesthesia. None of the dye is in the intervertebral foramen or the epidural space, and none is over the phrenic nerve. So it could be a phrenic sparing block if anybody wants to do that, the costoclavicular block. So if you have got any questions.
Sir, are we going to go for,
Yeah,
infraclavicular?
yeah, we are going for the parasagittal infraclavicular. And then we have retroclavicular and then we have axillary, but I don't know whether we have got sufficient time. It's almost now 40 minutes.
I think we can finish the, paracardial approach, and then can we go for question answers?
Yeah, yeah, we can do that. We can.
Yes, sir.
So we are going for the traditional or the conventional parasagittal infraclavicular block, where the probe is positioned medial to the coracoid process, and it's in the parasagittal approach. So when we start dissecting, we need to remove the pectoralis minor, and when we remove the pectoralis minor, what you can see here is now you can see the we come from the cranial to caudal. So this is the cranial, that's the caudal, that's the lateral, this is the medial. So we have from the lateral the vein, the subclavian artery, the brachial plexus, which we have already seen for the costoclavicular block. But when we descend more caudal, we see some of very important structures. One important structure that came to us immediately was the axillary artery and the circumflex axillary artery and the axillary nerve, which arises from the posterior cord. So it lies very deep. This is again the vein, that's the artery, and you can see the cords of the brachial plexus which lie around the around the artery. And you know the position of the cords. This is the pectoralis major which we have removed. That's the pectoralis minor which we have removed. These are all thiel embalmed cadavers. So they look like almost like what we see in our routine clinical scenarios. Now, this is probably a video, not a video. So this is what we see, the sheath of the brachial plexus. What we have done is we have removed the entire sheath of the from the brachial plexus in the infraclavicular area. They lie all in one sheath. Just below this finger, if you try to look at this, is the middle cutaneous nerve of arm and the forearm, and that's the axillary nerve. That's the axillary artery and circumflex axillary artery, and these are the cords of the brachial plexus that we are soon going to follow. So they all lie in one single sheath. So in the past, when we used to inject in the axillary area, we just used to target the median nerve quite low here at this point, so that the drug used to ascend and it used to go circumferential all around. Now, when we look at this, is the lateral aspect, that is the cranial aspect, this is the medial aspect, and this is the caudal aspect. So here, what we see is we see the axillary vein here. So this is entire the axillary vein. What you can see here is the artery, the axillary artery, and you can see the posterior cord which lies exactly below the posterior to the axillary artery. The middle cord, we have been reflected between the vein and the artery. We have pulled this between the vein and the artery. So the artery, the vein, and you can see the cord here is the middle cord. More posterior is the posterior cord, which is exactly posterior to the artery, and this would be the lateral cord, which of course give rise to all those branches. So here we have something very different, and it's all related to the artery here. In costoclavicular, everything was clustered lateral to the artery. Here you will find the the artery in the center, the lateral cord which would be lateral to the artery, the middle cord which would be between the vein and the artery, and the posterior cord which would be posterior to the artery. So at three different sites. And that's important is the pectoral branch of the thoracoacromial artery, which is one important thing that's going to come in your way when you insert your needle. So when you come to the cross sections here, what you look at the cross sections, you look at the pectoralis major, you look at the pectoralis minor, and below the pectoralis minor would be the neurovascular structure here, which is always on the second rib, and the subscapularis muscle, which comes into picture here. You have the axillary vessels, the artery and the vein. This would be the lateral cord. That would be the medial. That would be the medial cord, and this is the posterior cord. So in the cross sections, you may not see as you can see in the dissected specimens. You can see the topography might change from specimen to specimen. Now, as I mentioned earlier, when you have uh, the medial cord, the posterior cord, and the lateral cord, of course, they have got the fascicles. The dark browns are the fascicles. These are all the fascicles which are embedded in the non-neural tissue. So this is a neural tissue. The fascicle is the neural tissue, and this is all embedded in the non-neural tissues. So it's present everywhere, and it can differ from cord to cord. It can differ from individuals to individuals, and it can differ intra individuals as well. So it may not be the same on the other side. It can be different. So the ratio of this neural to the non-neural tissue is very important. Maybe we might have a lecture on that the next time, where it determines the importance of the nerve injuries and the block efficacy. So this could be a part of the lateral pectoral nerve, which is just emerging from the lateral cord. This is the entire the posterior cord. Now this is encircled with the as we have mentioned about the paraneural sheath or the circumnerium, and this is all the connective tissue, which is fat and all the layers of the collagen fibers here, which all gets embedded into this tissue. So it's very important that when you insert your needles, you need not penetrate this. It's again the same importance lies for all the cords. So when you are directing your needle tip at this important areas, there are three areas where you have to inject your local anesthetic if you're going for the triple injections, but we usually go for a single point injections. So we do not target the nerves here. We target the artery and just posterior to the artery where there's a layer of fat here. You can see the layer of fat. And when you start injecting a local anesthetic here, we find that, and I mean everybody finds that the drug spreads in what you call as a donut sign or a U-shaped thing, which you will always visualize. And this is what we are targeting here. So if you target that, it becomes probably the most harmless injection of local anesthetic. But you always find that this cord, posterior cord, is present exactly at this point, just below this. So you need to be very careful again when you position your needle tip. Now, when you do an infraclavicular block, you can say that this is a sagittal section. The previous one was an axial. This is the clavicle. This is the axillary artery. This is the brachial plexus elements. Now, when you insert the needle is going to be in plane, and it has to be in the parasagittal approach. So this is the parasagittal placement of the probe, and this is the needle placement. You can see hardly there is a distance between the probe and the needle trajectory. You can also see the thoracoacromial artery branches which are coming in way, and you can see that the lateral cord will come in the way when you are trying to position a needle posterior to the artery. So a couple of important things I mentioned, you have to keep it in mind. You can see the beam is not equal. It starts with very minimal and then it increases as you go more deep. It means that the tip of the needle, it might be difficult to visualize. So that's the brachial cord. Now, once you start injecting your local posterior to the artery, you can see that there's a paraneural sheath here. You can see there's a displacement of the artery cranial. The cords are displaced more posteriorly. You can see that this is a very fragile paraneural sheath. I'm just demonstrating again how this paraneural sheath can be easily penetrated, and then you can see the brachial cord here, the posterior, and the entire paraneural sheath here. So it's very important to recognize this. I'm just demonstrating again. So this particular sheath is being penetrated. As you penetrate that sheath, you get access more towards the posterior cord. Just beyond that, and then inject your local. So now the needle has penetrated this. This is the posterior surface of the artery where we are targeted. You can see that is separating the cord from the posterior aspect of the artery, multiple sleeves, and then you inject your local anesthetic here. And then the local anesthetic is going as a U-shaped, or what is they call as the reverse donut sign, whatever. Now you can see that the cord here is now engulfed with the local anesthetic. So does it not mean that when you inject posterior to the artery, the drug is going along the facial layers, like what we mentioned earlier, along the adipose tissue, which occupies here, and then this leads to the adipose tissue or the connective tissue around the cords. So this is a bunch of the medial and the posterior cord probably. That's why it's a huge structure. And you can see now the entire thing which is engulfed. And these are the cords of the brachial plexus. So what usually happens is that when you start injecting posterior to the artery, you can see the lateral cord, medial cord, and the posterior cord, which is surrounded by the local anesthetic. So it means that there is a connection between the posterior and the medial and the posterior and the lateral. And usually there are two septa here. There's one septa here, you can feel a click. You go beyond this, inject towards the lateral cord. And then there's one more click at this point, and you inject at the posterior cord. And this is the circumnurium. This entire is the circumnurium. So this could be the circumnurium between the lateral and the posterior. This is the circumnurium between the medial and the posterior cord. So this is finally the needle trajectory here. You can see the needle trajectory from cranial to caudal, and just below the artery, there would be a sheath, a small pop here, and you start injecting local. It starts spreading immediately, and there's a communication between this area posterior to the artery and the brachial plexus, and then it communicates. As you can see, this communication, the arrow shows the communication from the posterior to the medial, from the posterior to the lateral, and you can see the circumnurium area, and you can see the sheath of the brachial plexus here. Now what important here is for me and for all of us is that this volume of local anesthetic is important for the posterior cord. This volume is important for the lateral cord. This volume is important for the medial cord. But this volume of local anesthetic is, of course, of no use because it's lying beyond this sheath, and it might penetrate or may not penetrate. It all depends upon the concentration gradients. So this area is the one which will go without any benefit. So probably when I start injecting local, I find that I do a dynamic scan of the posterior, medial, and lateral cord. And if I find that more volume of local anesthetic is going in this space, I stop injecting local because this is not going to give you any benefit. And we are going to come that to it again in few more slides. So again, this is the final picture where you get the posterior cord, the local anesthetic here. You get the medial cord, you get the local anesthetic going around it. You get the local anesthetic going around the lateral cord, and you don't find any other volume of local anesthetic. So this is the most optimal image of the infraclavicular, where you don't find a drug going in non I mean like those areas which are not required. So or the wasted drug, you can say. So this is the optimal volume of local anesthetic. So 5 ml of local at each point would suffice, or you can give just one injection of local and 15 ml here, and when you try to see the injection in dynamic scan that the medial, lateral, and posterior cord are all involved, it means that the block is optimal. So again, you'll find here the lateral cord engulfed in local anesthetic, the posterior cord which is engulfed in the local anesthetic, the medial cord which is engulfed in the local anesthetic. But you can see now beyond the medial cord, you can still see the local anesthetic. So in this case, if you start seeing the local anesthetic in some unrequired areas like these ones, or maybe these ones, you can see these ones as well. So these ones are not necessary at all. So probably this, I'm not sure whether it's a neural structure because it's originating from the lateral cord, and this is giving a communication here at this point. So probably this could be a neural element. I'm not sure about this, but the local anesthetic 1, 2, 3 and 1, 2, 3 would be really not required. So needle tip placement is posterior to the axillary artery. Now we published an article where we injected posterior to the artery as was demonstrated earlier, and we found that it stains everything the lateral cord, the lateral root of median, the medial root of median forming the median nerve, the radial nerve, the lateral cord giving the musculocutaneous nerve, the axillary nerve arising from the posterior cord. So all were stained with this. So a single injection has stained all these lateral cord, posterior cord, and the medial cord. So there's no necessity of injecting at three areas unless you really find it difficult to engulf all the nerves with local anesthetic with one single injection. Then we did cross sections and we found that if you inject posterior to the artery at this point, it is going to engulf the posterior cord, the lateral cord, and the medial cord. So you can see the fascicles of the the lateral cord, the posterior, and the medial cord as well. So this is how you block the infraclavicular brachial plexus with one single point injections. Now, when you look at the infraclavicular block, sometimes I feel that the infraclavicular is really the spinal of the upper arm, and it's not the subclavian perivascular, which is the spinal of the upper arm. Now, why? Because I have done a couple of cadaveric studies, as I've demonstrated, and I've done contrast studies. You can see this at the lower cervical area. This is the cervical vertebra, and you can see the dye close to the brachial plexus. This is at the level of T1, T2, where you can see the dye close to the brachial plexus. You can see at the in the thoracic area, we can see again, of course, this is the infraclavicular area, which is bounded by the pectoralis major. We can see this is the pectoralis major. This could be the serratus and the subscapularis. This is the spine of the scapula. So this is the subscapularis muscle, the subscapularis, serratus, the pectoralis major, and then caudal, it moves on into the axillary brachial plexus. So if you look at this again, it's exactly engulfing the artery. This hypoechoic shadow is the artery, and engulfing and around would be the brachial plexus. Now, if you can see that this is a hypoechoic area, this is a hypoechoic area, and the next slide, I would like to demonstrate what this hypoechoic area is. So the infraclavicular brachial plexus, the boundaries, pectoralis major, pectoralis minor, the serratus anterior, the subscapularis, and inferiorly it moves on into the axillary brachial plexus. So what are these hypoechoic areas? Now these hypoechoic areas, which have been marked with green, and now they are made even more prominent. This is all fat and the connective tissue here, where you can see that local anesthetic is now trying to go into this space. But since this is a continuous catheter, we inject around 5 to 7 ml in the for the postoperative pain or maybe the infusions. Now, if you inject around 30 to 40 ml of local, it's going to go into this space and probably into this space. And this space is the one which leads to inadequate blocks. So if you find that, as I mentioned earlier, these are the same space, and this is called as the thoracoscapular space, and this is very well mentioned by my friend George Fiegel. Now these hypoechoic spaces have been defined. Now these have been defined. Look at this, the same thing. This is the humerus, that's the spine, this is the subscapularis muscle, this entire the thoracic cage, this is the serratus anterior muscle. And when you start injecting local, this is the optimal site of the local. But if you see that the drug is going into this space, that becomes the thoracoscapular space. And this is the reason why there's a possible explanation of failed blocks with the infraclavicular approach, and this has been observed in the cadaveric studies. So this is very important to understand that this space can lead to, if your drug is going into this space, this can lead to failed blocks in the infraclavicular approaches. This is again the coronal sections where you can see that this is the subscapularis. So this is we are more posterior, we are coming more anterior, and this is where on the first strip. So the drug is going all across the almost at the level of the first strip, very close to the serratus anterior muscle, very close to the serratus anterior muscles. And this you can see more prominent in the next section, where you can see in the coronal views. This is one cord, that's the artery. So the red one is the artery. You can see the white is the contrast which is going around the artery. So that's the The cords are on the brachial plexus. This is again the contrast, thick one going around the artery. So that's the brachial plexus. Again, the same here, and this would be the same here. Now, what interesting I find here is that from this area of the cord, which is the posterior aspect, the drug percolates onto the serratus anterior plane. So this is the rib 1, and that's the rib 2. This is the intercostal muscle. And I find that the drug, it percolates onto the serratus anterior muscle. So are there any connections between the posterior cord and the serratus anterior muscles? Because this is quite a unique feature. And if we give infraclavicular block and we find a high SAP block, that could be a very interesting uh, manifestation for the future. But I'm really not sure whether this is consistent. We'll have to do a clinical evaluation after giving the infraclavicular block. Every time we have to assess the uh, the uh, the T1 and the T2 whether they have been blocked with the infraclavicular as well. So high SAP block, which would be a beneficial effect of an infraclavicular block with 30 ml of local, would have a good future in for the few of the surgical procedures as well. Now, why I say that this is the spinal of the upper limb, basically, what I have seen is when you start injecting in infraclavicular, the drug ascends right up to the retroclavicular, the supraclavicular, and the interscalene. So forget about the costoclavicular block, which we have demonstrated earlier, where the drug had reached the level of the supraclavicular and the interscalene trunks. Even the infraclavicular block, if you stimulate the posterior cord, especially, we have seen that the drug ascends and goes right into the interscalene area. And this is the axial section. This is the sagittal section, which shows the lateral cord, posterior cord, and the middle cord. And this is the axial, where you can see the drug ascending right into the interscalene area. So probably I feel that this is the spinal of the upper leg, where it will block all the nerves. There won't be any ulnar sparing, which is more common with the supraclavicular. There won't be any radial sparing, which is more common with the axillary. And there won't be any muscular cutaneous sparing as well, because the infraclavicular blocks the at this level, and which is a problem with the axillary blocks as well. Now, why is this? Is because if you have seen that this is a perivascular perineural facial layer, which if you insert from the axilla, you can see that it comes right up to the cervical level. So probably there is a continuation of the tubular sheath, which actually comes from the C5 and the C6, the whole of the brachial plexus, then travels and it ends at the mid arm almost. So this is a continuous sheath, and you can take advantage of injecting local anesthetic and inserting catheters for postoperative pain relief. So if you have got any questions.
Thank you, sir. It was an excellent presentation as always. Sir, my question is, as you said, paracarotid approach, with single injection, you get the good effect for all three codes. So earlier with PNS guided blocks, we were used to stimulate posterior cord and injecting higher volume like 30 ml. So with ultrasound guided block, how much volume is required for blocking all three codes?
So actually, they have come out with some minimum effective volume of local anesthetic for costo for the infraclavicular. Now, as you have rightly said, that we used to target the posterior cord, elicit the evoked responses, and then inject around 30 to 40 ml of local. But now with ultrasound, we are doing it real time. So when we start injecting local, we see the local anesthetic engulfing the posterior cord. Then we go a bit more, scan, shift the probe medial, try to see between the artery and the vein, the middle cord, and try to see, visualize how much volume or how much the cord has been engulfed, and at the lateral cord. Now, if we feel that it's insufficient, of course, we withdraw the needle and then we inject part of the volume into the lateral cord, and then you go medially between the artery and the vein and the posterior cord. So the limit, how much would be the limit that you're going to inject until you decide that you go for the other cords? Now, 15 ml of volume is good enough to have a conclusion that beyond this, there won't be any drug percolating to the medial and the lateral cord. Then you keep on withdrawing the needle and inject separately at the lateral cord and the medial cord. That's what we do, Hetal.
Yes, sir. Thank you, sir. Another question is regarding circumneural injection. So, in costoclavicular approach, we inject beyond circumneural sheath. But as you rightly said, sir, with ultrasound, sometimes we go beyond epineurium also. And recent study, some of the study says that if you go, interfascicular, then there won't be any nerve injury, and even there won't be any rise in the injection pressure. So, is injection pressure monitoring really helpful to prevent the, nerve injury?
So now we have been told, and we have been often informed that you need to have a triple monitoring. You have a peripheral nerve stimulation less than 0.3 milliamperes. You're not supposed to inject. With ultrasound, if you see there is a increase in the 15, there is an increase of the nerve size by how much? Like it's quoted, Hetal? I don't.
It is shown that swelling on the any fascicle. Yeah.
Swelling of the fascicles, but there is certain value of the size. Beyond that, if it increases, you stop injecting local. And the third is the 15 to 20 psi. That would be very high when you look at it using the pressure monitoring. So actually now the intraneural, of course, we have been informed that's not to be done. But Paul Bigelsen in 2006, he has come out with an article where he has purposefully injected around 0.5 to 1 ml of local inside the nerve, peripheral nerve, and he has not found any patient complaining of any radiating pain or any symptom or sign, and never peripheral nerve injury after 6 months. But having said that, there have been a couple of articles again to remind us by some of the top regional anesthesiologists around the world that the intraneural injection at any cost has to be avoided, and it has to be a circumneural or paraneural injection. So as of now, even for the students as well here, paraneural injection is the one that you have to go with. Intraneural injection has to be avoided at any cost. And at any point of time, if anybody asks you, you can still conclude that the intraneural injections are still under investigations, and there is nothing that we can conclude that the intraneural injections are safe. So that is what my take on this, Hetal.
Yeah. So recently, only in RAPM, one of the RAPM article, they studied histology, and they found that there is lots of connective tissue around fascicles, and sometimes even we go inside epidural sheath and we inject the drug. There won't be immediate increase in the pressure because there is lots of connective tissue. So sometimes.
Yes.
If you are looking at only injection pressure monitor, then you might be intraneural and you fail to notice it earlier. Sir, another question from my side is, as you said, with the costoclavicular approach, drug spreads proximally also, and it goes up to cervical roots. So, phrenic nerve palsy chances are there even with costoclavicular block. So, should we go for, costoclavicular block for shoulder surgery, especially in patient with COPD, or we should avoid it?
Now, there's only one cadaveric study by Koela Moody where she mentions about the dye which migrates from the costoclavicular to the supraclavicular area, and the phrenic nerve is hardly stained. I'm unsure about the percentage about so that's called the anatomic phrenic nerve block. So I'm unaware about the percentage. But having said that, the costoclavicular would be more suitable for patients with chronic obstructive airway disease. But I'm unsure really about how much percent of suprascapular nerve would be blocked, which is still supposed to be a major innervation of the shoulder joint.
Yes, sir.
Because the lateral pectoral, the subscapular nerve and the axillary nerves, They of course innervate the joint, but to a lesser extent. Because what we did was, Ethel, we in a few cases in a pilot study, we just gave the costoclavicular block without giving the suprascapular block. And in the other group, we gave just the anti-suprascapular nerve block, and we found that the patients hemodynamically intraoperative, they responded better with the infraomoid suprascapular nerve block and not the costoclavicular block.
Right, sir.
So it does mean, so we gave up the study because we found that anyway the patients are not being benefited, and in the post-operative period they did require additional rescue interscalene block. So there's no point in going with just the costoclavicular block, is what my supposition is. Probably you can add a posterior suprascapular block, probably in that case,
Right,
to
sir.
the costoclavicular block. If you really want to avoid the phrenic nerve, because beyond 5 ml, again the phrenic nerve block incidence is high with the, not high, but it's still there with the anterior suprascapular.
Right, sir. Sangamitra, any other questions from, participants?
There are some in the chat box, sir. 1 second.
So we'll do this the second time, the retroclavicular and axillary, because we have the same number of slides, and which would be difficult to cover now. So we
Right,
can do
sir.
it as a short. We can do it as a short talk the next time.
No, we can go for extensive talk, sir. We are okay with it.
Yes, sir. So there's a question from Dr. Nived that in parasagittal infraclavicular block, also drug ascends to interscalene groove.
That's what I showed, no? So it may not be all the time. Whoever has asked this question, it may not be all the time, but if you can see this with the infraclavicular block, if you can see here, I have injected at this particular point, and this is with the peripheral nerve stimulator. It's not with ultrasound. Now with PNS, I have injected for 30 to 35 ml of local anesthetic, and you can see the drug ascending along the neural sheath. So this is the costoclavicular, this is the retroclavicular area, this is the subclavian area. We can see a lot of hypoechoic shadows here. You can see the divisions, a lot of divisions here. And then you can see that it ascends as a streak up to the interscalene. But the volume of local anesthetic, what you inject here, is basically meant for the infraclavicular. Now, how much volume reaches here and how much the patient gets a benefit out of it for the shoulder joint, I'm really not sure about it.
It's like ESB injection reaching the thoracic parietal space.
Right, exactly.
As of now, sir, no more questions in the chat box.
Okay.
If you have any questions, you can raise the hand and you can ask any of.
Directly, yeah.
Yeah. Someone is. No. If there is no question, we can conclude the session.
Yes. Thank you, Ethel. Thank you, Sangha.
Thank you, sir.
Thank you, sir.
Thank you so much. Yeah.
Sir.
Thank you. Bye.
Thank you, sir. Good night.
Good night. Thank you so much.
Thank you.